a reminder, talking about gold, gold is not a guideline. There's something about the 2 Gs that make you automatically say gold guideline, but it's wrong. It cannot be a guideline for 2 reasons. First of all, you cannot have a single global guideline. Guidelines must depend on what you have available, not just medications, but also resources in general, and therefore you cannot have one global guideline. Secondly, we do not use strict guideline methodology with PICO questions for every decision making. It's simply too time-consuming and expensive if you want to have a live document. For this reason, it's a strategy document. You can then use it or take ideas from it for guidelines, but it is a strategy document. We revise it every 5 years, which is really going through it and making major changes, updates every year, and they should not be major, but sometimes they are. And basically, we discuss it more or less all the time. I'm going to discuss the update of 2019, and if it goes too quickly, there will be a paper which is in press in the ERJ, which will appear very soon. You can already find it on the website, which explains a bit of the background thoughts for why the changes were made to the 2019 report. The controversies are mainly the use of A, B, C, and D, the new treatment algorithms for follow-up and change of treatment. There is the whole role of ICS-LABA versus LABA-LAMA versus the new triple combinations. And finally, a few thoughts of what should come after this. Nothing has changed in this. You spirometrically confirm diagnosis. You assess the degree of airflow limitation. You could say this is for prognosis. I would say it's more for characterization. And then you go into the ABCD for treatment decision. 2019 looks like 2018 and 2017 regarding A, B, C, and D. No changes there. I think nobody ever noticed that these lines are dotted because, of course, there's no big difference between a cat of 9 or 11. It's just to signify that some are sicker than others. And if you get bogged down on numbers, you'll be in trouble. So that's just a short warning. This is the old one. We then said within A, B, C, and D, you could make these subsequent changes. This is wrong. It was wrong to begin with, because once you start treating patients, they change. Hopefully they get less breathless. Hopefully we control their exacerbations. So it doesn't make sense to say that somebody who was once a D patient and now has better control of exacerbations is a B patient and therefore cannot be treated like a D patient. It just doesn't make sense. For this reason, A, B, C, and D is only used the very first time you see a patient. The very, very first time you classify your patients into A, B, C, and D and decide a treatment. Then you follow the patient up and see how they are. Can you do more for their breathlessness? Do they still have exacerbations? And the smart one can see that you can get quite far with just starting with a long-acting bronchodilator without even thinking with gold. And whether that's correct or not, we can discuss, but that's the choice. Then this figure we've been told this is too complicated. General practitioners will never, ever understand this. The reason is that we try to explain how we think in a diagram, and that is rarely easy. But this is not complicated. If you're a general practitioner and you look at how they risk score ischemic heart disease or how they manage type 2 diabetes, this is a walk in the park. Basically, 2 angles to it. Breathlessness, you start with a LABA or a LAMA, we've not specified, because it'll depend on a number of other things than exactly what the head-to-head comparisons have shown. A lot about availability. If the patient is breathless on one, you can try to combine them. And after that, you sort of think, have I done the right thing? Can the patient use the inhaler? Hopefully you've given some thought to that previously. But also you think, could this patient have heart failure, atrial fibrillation, too obese, anemia, all the other things that can cause breathlessness. If the patient is only breathless, does not have exacerbation, but is on an ICS-containing regimen, you could consider stopping ICS. It could be that you put the patient on them because of exacerbations, and you don't want to take them off, but you should consider it if you're only talking about breathlessness. The other one is a patient with exacerbations. If they've been started on a LABA or a LAMA, we say that there are basically a choice to be made, and that is to go on the route of the LABA-LAMA combination or the LABA-ICS combination. And we have, and I can come back to it, we can discuss it, say those who need an ICS-containing regimen are those who either have blood eosinophils above 300, or if they have eosinophils above 100, they have some features which we think ICS are good at regulating, especially frequent exacerbators and also the very severe exacerbations. We do not advocate at any time ICS to patients with blood eosinophils below 100 because we don't believe there's one single study that has shown it has superior effects to using two bronchodilators. Those who are on a LABA ICS, if they continue exacerbating, you add the LAMA. Those who are on the LABA-LAMA can, if EOS are above 100, you can try it, or otherwise you can go to roflumilast or azithromycin. Azithromycin we have limited to former smokers, which I must admit is only based on post-hoc analysis, but they have been quite convincing. So this is what we do. Again, if you are on an ICS-containing regimen and you don't seem to respond to the steroids, you could consider stopping them, although for practical purpose, I don't think you would be very happy with stopping an ICS in exacerbating patients unless patients had many pneumonias or only had infectious exacerbations. Focus on eosinophils. I'm not going to show you a lot of slides about eosinophils because you've seen many of them before, but they look like this. And basically down here you have the effect of adding the inhaled steroid to the LABA compared to the LABA alone. And you can see that you have increasing efficacy, which probably starts somewhere between 150 or 200 to be significant in these trials. And when you reach 300, you probably have a 50% reduction, which clearly you would be very, very strange in not putting patients with that sort of an effect on this drug. So that's the 300. You should really have a good reason for not putting a patient on it. When you get to 100 or below, you should really have a good reason for putting a patient on inhaled steroid. What we also taken into account, do patients feel this? And we have used the analysis of SGRQ. It's been looked at in two studies, one from the FORWARD trial where beclomethasone was added to formoterol, and we could show that in those with high eosinophils, there was an improvement in SGRQ score of 6. And you can see here that when you get up to around 400, you clearly have an effect, which we rarely see in trials where you compare two active compounds. In the old one, the central thing was, of course, the triple, but also there was the LABA-LAMA as the preferred starting point. And you heard yesterday that that was very much based on the SPARK trial, which was, in fact, not very impressive. And we've seen the Dynagito trial, and it shows exactly the same. These two trials are as much alike as you would ever see trials. And I think it just shows that when you compare something to a very good long-acting anticholinergic, you have difficulty showing benefit of further bronchodilation. So we thought it was not reasonable to say that you should automatically start on a dual bronchodilator instead of a long-acting anticholinergic alone. The other thing was the debate whether an ICS-containing regimen was superior or not when it was an ICS-LABA compared to a LABA-LAMA. We had the FLAME trial with its shortcomings, but also very consistent findings in this setting of patients without any history of asthma, with a limit on eosinophils and with a focus on safety of this trial. And then, of course, in contrast, as you saw yesterday, the IMPACT trial, where the rate of exacerbation was considerably lower on the ICS-LABA than on the LABA-LAMA. And I think you also saw Paul Jones showing the slide that the two studies are not necessarily showing different things, but they are indeed looking at different patients. So this is from the IMPACT trial, the overall risk of having exacerbations if you're on a LABA-LAMA compared to a LABA-ICS. Or you could turn it the other way and say on a LABA-ICS you would have a 13% reduction of exacerbations. But if you split it in those who have few exacerbations or those who have many exacerbations, you can see that the benefit of the ICS-containing regimen is in those with more severe disease. Which is why we say if you don't have eosinophils over 300, but you're between 100 and 300, many exacerbations, severe exacerbations, you are a candidate for an ICS-containing regimen. This one, just like the old one, does put triple therapy in the middle, and I must admit that until very recently we had extremely poor evidence for this. The evidence doesn't come until somebody puts all the three drugs in one device, and you have to come up with large registration trials for this. And I'll just describe a few of them very quickly. These are the trials that have been done with exacerbations a primary outcome, looking at moving from LAMA to triple, ICS-LABA to triple, or LAMA-LABA to triple. The first one we did with one of the combinations, comparing it with tiotropium, but also the European agency asked us to compare it to an open triple simply by adding tiotropium to an ICS-LABA, or rather the same ICS-LABA as in the fixed triple. It didn't really matter what triple you used, it was significantly better than tiotropium. When I presented this at an ERS Congress, there was one of our dear American colleagues who jumped up immediately and said, this was the most ridiculous trial he'd ever seen. How stupid could you be? Of course, using 3 drugs would be better than using 1 drug. And I just had to remind him that this is the first 1-year study ever to show that anything is better than tiotropium in reducing exacerbations. And it just shows that tiotropium is a good drug. This was also one of the first trials where we prospectively had specified that we would look at eosinophil subgroups. We didn't quite know where to make the splits, so we made it 2% and 200. If you look at the 200, those who had eosinophils below 200, the effect of a triple compared to tiotropium is negligible. It is very, very small. Whereas if you look at those with eosinophils above 200, you have a 36% reduction of exacerbation. So clearly the eosinophil signal, whatever it reflects, comes out very clearly. I'll skip this one. I'll go straight to the impact trial because this one compares the fixed triple to both the LABA-ICS and the LABA-LAMA and shows superiority to both. And Paul Jones went through this study in more detail, but it clearly adds very large weight to the evidence. It was a very large trial, but also in a slightly different population than most of the previous trials in COPD, with them being much sicker, and also that the way they were taken into the study probably differs a little from others. The last trial is just the other fixed triple combination compared to Ultibro. So this is actually a twice-daily triple compared to a once-daily LABA-LAMA, and still you see superiority of the triple compared to the LABA-LAMA, which in this case was Ultibro, because we thought that that was the LABA-LAMA combination, which when we designed the study, had the best track record in reducing exacerbations. And of course, as soon as you have more than one study, you will have a meta-analysis, and this is one of triple therapy published in the BMJ quite recently, and not surprisingly, they came up with the conclusion that triple therapy resulted in lower rates of exacerbations, better lung function, better health-related quality of life. And of course, because of the side effects, what we do in GOLD is that we advocate ICS for the exacerbation lowering effect, not for the effect of lung function. And the reason is, of course, the pneumonias. I still think that the TORCH data are the most impressive data for the single reason that we didn't look for pneumonia. It came as a big surprise. So it was not as if the way they were registered was fixed in any way. They just came into the clinic and said, since I was here last time, I had a pneumonia. And when we thought that could not be, and we looked at hospitalizations, we saw the same thing. How does it look with pneumonia in the fixed triple combination studies? Well, the first one I showed you with triple compared to tiotropium, there was a 40 to 50% increase in pneumonia in the ICS-containing arm, which is exactly what you would expect. For some reason, in the tribute trial, there was no difference between the LABA-LAMA combination and the triple combination, but as you can see, the number of pneumonias was fairly low, 28 and 27, so I would take this with a grain of salt. In the larger trial, the impact trial, much larger numbers, more severe patients, you could see the same thing as we saw in TORCH with the other fluticasone derivate, a 50 to 60% increase in pneumonias. So, then what? Because this is a sort of quick run-through of where we are at the present. What are the challenges? Because I can assure you that we do not spend all the time just discussing p-values and whether one compound is slightly bigger or better than another. I think when you're involved in GOLD, or basically any other guideline, there's always the balance to be struck between being conservative, which I believe is a virtue for a strategy document, or being bold. And I think last year showed that we were probably too bold on the LABA-LAMA dominance. So there is a risk of jumping with the first. I had a mentor in Copenhagen when I was young who told me that you should not be the first to start a patient on a new drug. You shouldn't be the last either, but don't be the first. It's better to wait a little. And I think probably gold would deserve some credit from not being the first mover necessarily all the time, but being a bit conservative. The other thing that we've discussed a lot, because COPD is very rarely seen alone, whether we should continue looking at COPD as the main disease in the world with some comorbidities, or whether we should enter the field where actually we deal with multimorbid patients, and we should rather describe COPD as part of multimorbidity, which is much, much more difficult, and the evidence much, much weaker. So we've never gone into this area, but the discussion is still there. And then I think probably even more importantly, we need to agree on how we assess evidence when we move into more personalized medicine. Because that means that we will never have the large trial. My mentor also told me never change treatment until you have 3 trials from 2 different parts of the world. We never have that anymore. You go with 1 or 2 trials, you may even go with a post hoc analysis. And that's the challenge of how we base our evidence when we try to find subgroups or new treatments. And then, of course, with COPD or asthma and COPD, we keep asking ourselves, what's in a word? What is COPD? Do we have different obstructive airway diseases, or do we have airway obstruction with treatable traits? But that's for another day. Thank you for your attention.